Thank you very much. Good evening. I am Joel Silverfield, the President-Elect of the HCMA. Welcome to the HCMA's third COVID-19 virtual town hall. There was an ancient curse that stated, may you live in interesting times, and I would say that we are living in interesting times indeed. Just a few months ago, we went from no one knowing much about COVID, not knowing anyone who had it, to where most of us either know someone who's had it or their families have been touched, including my own. There have been more than 1,200 articles that have been written just in the last few months, and there have already been many extractions. We've had an unprecedented tsunami of information, but as we all know, information is not wisdom. Wisdom comes from experience and time. What we'd like to present tonight with our experts is the information to our doctors. And unlike the political debate that will be following us, we're hoping to give you excellent facts and some clarity. It's been said that you're entitled to your own opinion, but not your own facts. So the facts are changing. This whole landscape is changing. We are fortunate. Before we begin with our panelists, I'd like to talk about them for a moment. We have a superb group of academic, scientific minds, probably as good as Florida or the Southeast has to offer, but they are also no strangers to the bedside. These are all people who have worked as clinicians as well. So I think that's the ultimate in what medical science can offer. Dr. John Sinnott is an infectious disease specialist, the chairman of internal medicine at the USF Morsani College of Medicine, and the director of the Florida Infectious Disease Institute. He is also the former Associate Dean of USF Medicine International. Dr. Douglas Holt has been the health officer of the Florida Department of Health in Hillsborough County since 1996, before some of these medical students were born, Dr. Holt. He is also a professor of medicine at the USF Morsani College of Medicine, Division of Infectious Disease and Internal Medicine. Dr. Cami Kim is the director of the Division of Infectious Disease and International Medicine at the USF Morsani College of Medicine. In addition to running her laboratory, Dr. Kim is a practicing infectious disease physician. Dr. Charles Lockwood serves as the Senior Vice President of USF Health and the Dean of the USF Health Morsani College of Medicine. He is a tireless advocate for the training of physician scientists. Thank you all for your participation in HCMA's third COVID Town Hall meeting. The questions our panelists will be answering this evening are those that have been previously submitted. If there is time at the end, we may be able to allow for a few more questions from viewers. To submit your questions, please type them via the chat option on your screen. Now, let's get started. So Dr. Kim, I think we'll start with you. Has this virus mutated? And if it has, in what way?
Well, so this type of coronaviruses has less of a tendency to mutate than some other famous viruses like HIV. I think there's some very, very good evidence that it has mutated, and there's some evidence, less completely convincing, that the mutations have affected the virulence and infectivity of the virus. But that's obviously the million-dollar question, because all viruses mutate, but they may or may not be clinically significant. And I think that's the thing that we're going to want to know, and will affect both response to treatments and potentially vaccines. So yes, it's mutated. We don't know how clinically significant is. There are some reports that it may have changed infectivity and virulence.
I see. Does blood type matter?
Does blood type matter? So that's a little controversial. There were some case reports, there's a GWAS study, a genome-wide association study out of Europe that suggested that blood type does matter. Then another study that suggested maybe it didn't matter. And then I think I saw something else that said it does matter. As you know, one of the deadly consequences of COVID infection is a lot of the clotting complications that people have. People have strokes, they have heart attacks, they have pulmonary emboli. Blood type, particularly group A, is associated with increased thrombosis. So it's entirely plausible that blood type would be associated with more complications, but at this point, it's unclear.
I see. Dr. Sinnott, I'm going to give you the testing question. You know, this question gets asked on every one of these because you know what? It does keep changing. So the question I'm testing, who gets tested? When do they get tested? Which tests do you use? How reliable are they? And then if you would end up, you know, there's been a lot of literature about frequent testing and how that might get us out of this hole that we're in before the vaccine is available. And did the Trump recent debacle, does that show that frequent testing doesn't work?
I think that's 8 questions. Let me try with one first. The gold standard, probably 80 to 90% sensitive and very specific, is polymerase chain reaction on a deep nasal swab. And that tells you that the person either has the virus or they could be recovering, okay? I've had many patients that were PCR positive out 42 to 45 days, but they're just picking up pieces of RNA. You're really only contagious 8 to 10 days after the symptoms first start. So after the symptoms start, 8 to 10 days, the immune system has wiped out the virus. The second phase of the illness, the immune phase with leaky pulmonary capillaries and shock, then begins. So the PCR is the gold standard. You can do it on sputum. You can do it on a deep nasal swab. There's many ways to do it, but that is the standard. Now, there are some other tests. People have talked about saliva tests, things like that. They're not completely approved, and we're not sure of their sensitivity, their ability to pick it up, and how specific they are. Antibody testing, I used to tell people I couldn't figure out when I would use it. And then one of my attendings developed myocarditis. Mm-hmm. And what did I find myself doing? An antibody test to see if they'd been exposed. Now, these tests are not standardized well. It was negative, but since it was a pulmonary doctor, I'm sure he was exposed. So the antibody tests, most are of unknown meaning. If they're positive, that's good. For the patient, it means they've been exposed and are feeling better, hopefully. IgM would be positive 14 to 21 days out, and IgG should be positive much longer than that, several months. You could also test at a sophisticated laboratory. You could try to grow the virus, but that's only done for research purposes because it's such a dangerous pathogen. That's part one. What was the next part of the question?
So I guess the question you answered on the antibody was that you really can't think of a good reason to do antibody testing unless maybe it's something we would use from a demographic standpoint, trying to see who's been exposed and those kinds of numbers. But in general, and I guess the point being made is that if you're antibody positive, it doesn't guarantee you that you're immune. And then the other question that's a follow-up is, how long, if you have antibodies, how long do they last?
The IgG is measurable at least 42 days out, at least. But antibodies are not the only protection. We also have T-cell mediated immunity, which is indefinite, and it's probably as long as you live. That also plays a role. We're not quite sure. But I had another thought I want to add about immunoglobulins for practicing doctors. I had a patient, of all things, I just ran into someone I knew that was losing their hair and had been sick in August with COVID. So she was sick, I didn't know what it was. I got a COVID antibody and she was trending down on IgM and positive on IgG. So I wonder if you see a syndrome You don't know what it is. This is a new disease. We don't know if this causes hair loss or not. Maybe it does, but she's certainly antibody positive and her hair is coming out in chunks. So this is not something I've ever seen before. So I would encourage people to get a test if they're unsure, just so we can learn about it.
I think that's fascinating. Dr. Kim, there is a new term called long haulers. They have their own website. These are people who've had COVID and then having a lot of what they consider residual issues from it. Do you have any sort of segues with what Dr. Sinnott was talking about? Have you heard about that or know anything about that?
It's pretty common, and people not feeling right. There's a huge number of people who generally have a lot of fatigue, just generally feel well. I think a number of us think that this may be yet another cause of chronic fatigue syndrome, or that kind of a syndrome of thing where people just generally feel systemically unwell, but there isn't a that's it type cause. And then there's clearly other clear-cut systemic organ-specific disease, including many people who have lingering respiratory problems, have problems with their exercise tolerance. I think probably some people get chronic fibrosis of the lungs. We've even at Tampa General had a couple of patients who had such severe lung damage that they're on the lung transplant list. There's a lot of myocarditis out there. I think there's a lot of evidence that there's neurologic and neuropsychiatric phenomenon that may or may be specific or could be in that sort of chronic fatigue syndrome. So I think there's going to be a lot of long-term consequences. Of course, many of these people are still only a couple months after their diagnosis, so it may well be in 6 months to a year they'll be completely fine. But I think it's a misconception to assume that once you're over the acute disease that everything will go back to normal.
If I could perhaps add to that, there was a recent JAMA article. I just happened to have a photo of it. And on the other side, you see the persistence of side effects at 90 days. And a good 10 to 15% of people experience one or more of these. It's very troubling that we're making decisions when we don't know what the long-term effects of this infection are.
Dr. Lockwood, there was recently an article in Time magazine looking at that we may be looking at as many as 120 million people dying from hunger because COVID has interrupted the food chain and that sort of thing. And also they were looking at the number of stillbirths in poorer countries going up enormously. So from the macro standpoint, can you think of some things that COVID might be doing that we don't even think about?
Yeah, well, clearly it's having an impact on some very common things like stroke. And this is something we experienced here at Tampa General, has been reported widely nationally. People delaying seeing their physicians with early symptoms of stroke and then presenting at a point where they're really beyond the ability to revascularize. That's also true of MIs. So there's been an increase in non-COVID related cardiovascular and vascular mortality and morbidity. There hasn't been any marked effect on access to pregnant women in the United States, which is probably not unexpected. But I can imagine in those settings where access is so tenuous anyway, particularly Africa and South America, that doesn't surprise me. Obstructed labors, delayed labors, women that might die of hemorrhage from ectopics or postpartum hemorrhage. All those things I think are going to be contributing to the long-term health consequences of this disease. The issues and the global effects of the economic collapse that ensued the pandemic and our lockdown, I think have been underestimated by the left and exaggerated by the right in this country. I think that there clearly is a higher incidence of domestic abuse, suicide, depression. I can only imagine in areas that have unstable food supplies, the impacts that it might have there. So that I don't think is that may be a bit high of a number, but there will definitely be consequences. From the start of this epidemic, our political leaders were put in an untenable situation because they were forced to balance the public health good that would accrue lockdowns and strict social distancing and really a dramatic restraining force on the economy with the huge economic consequences of all that. And in turn, the indirect health related areas. And striking the right balance, I think, has been very difficult because there's so much we don't know, as you just heard, about this disease. And in retrospect, I think we will find that, first of all, the analysis of the immunological response to the disease, which focused almost entirely on antibodies, missed the importance of T-cell immunity, which half the population has to some extent because of our exposure to endemic coronaviruses cause common cold, 25% of cases. And we don't know whether or not that group represented the asymptomatic group. You know, and even in nursing homes, 50% of the patients that are infected are asymptomatic. Well, clearly, if it were simply age and morbidity and comorbidities, they would not survive, and yet they're asymptomatic. And so these are tremendously mysterious kind of aspects of this disease. We can't do the kinds of T-cell immunity studies that we can do in a sense with the antibody studies where we can just measure serologies. So we're going to know pretty quick, because if the numbers that papers in Cell and Nature suggest are true, that 50% of the patients have some T-cell made immunity, then we won't reach full herd immunity, but we'll have partial herd immunity sooner than we think, and maybe even before we have a vaccine. And maybe that accounts for why Florida hasn't had a big rebound in our cases. Maybe not, though. We really don't know. So there's a lot we don't know. And when you're in a position as a political leader to make these decisions, you're not getting very accurate information because it doesn't exist. So, you know, they've struggled. Both Democrats and Republicans across the country have struggled to try to hit that balance. New York obviously completely shut down their economy, and now because they perhaps suppressed the infections in healthy people, healthy young folks, they're now seeing a big rebound. Whereas we took a more Swedish type approach, not quite, but we protected our old folks for the best part, and I'm one of them. And we had a lot of infections among younger folks. The average age of infections in Florida is much younger than in New York. And so maybe we did it right by accident, because it was all by accident. So, you know, I think the comorbidities and mortalities indirectly associated with COVID have probably been underestimated and will be significant. And I think that Florida may have ended up doing exactly the right thing at exactly the right time. Wouldn't that be an irony?
Maybe the first time as well. Actually, I was going to ask Dr. Holt about whether he thought Sweden was good or bad in herd immunity, but you sort of touched on that. Let's see here. So Dr. Holt, the CDC recently has changed its tone a couple of times about airborne and droplet and that sort of thing to come under substantial criticism. What is your take on the CDC, how well it's done during this thing, and about this recent controversy about how the virus is born?
Well, I think really the CDC has done an admirable job under duress. I mean, they've really they've had a lot of misdirection about their getting off message, and that's just unfortunate. But the basic facts and the science, if you get away from that, they've been quite right on with things. I think the reference you're talking about is this question of airborne or aerosolization of the virus. And I think there's no doubt that within the spectrum of how this virus is transmitted, it has some significant contribution, but not the predominant way the virus is spread. But when you get into a situation where you have a fair amount of virus in your community, and particularly asymptomatics, and you've heard of the 3 C's with the avoid the crowds, avoid closed spaces, and close contacts. Well, with mask or in aerosolization, it's about the 3 V's. It's your venue, ventilation, and vocalization. So if you are in a small place, tight, poor ventilation, and it's loud, just like and for some period of time, you're putting yourself at risk for inhaling the virus. It's not that much different from, again, smoking, secondhand smoke. So, the whole idea that we can kind of separate our communities and keep certain populations separate from each other is impossible with this element if you are in that setting.
Thank you very much. Dr. Kim, a recent case came up whereby a family of 4 went fishing with a fishing guide, and they got a call 2 days later that the fishing guide's baby had tested positive for COVID. And this family was getting ready to drive up to North Carolina. And so they wanted to know what they should do. So they were exposed 2 days before to someone who had been exposed. So their question is, were they still okay? They didn't have any symptoms. Could they get in the car and drive to North Carolina? Should they be tested? Should they quarantine? And I think that's a question that we're all of us practicing physicians are hearing in our offices. Hey, I got exposed. Now what?
Well, I think the first thing is you have to figure out a little bit more details about the extent of the exposure, as far as how much time they spent with who they were exposed to, whether that person was symptomatic, a little bit more details about the circumstances, because the circumstances make a difference. So you want to be, well, you don't want to be, but the sort of criteria are, 15 minutes in close contact to somebody, but that's, influenced by whether both of you are wearing masks, whether somebody, was symptomatic and likely to be more infectious. A lot of the details actually really matter. So you have to know the extent of the exposure.
So that would be
how
long they were exposed, whether the person was symptomatic, whether it was closed quarters, whether they were wearing masks. In other words, you take all those things into consideration before you would advise them whether they could travel or not.
Yes. And the other thing is 2 days later is very difficult, because the incubation period is up to 14 days, but usually the first symptoms start at the earliest, like 2 days, right? And the peak, if you're going to be symptomatic, is probably day 5 up to day 7. So in the first week after exposure is when you're most likely, if you had a true exposure, going to come up with symptoms, but there's a long tail to that. And then also being in a car for that long, if only one of them's sick, probably everybody's sick. And it's really hard in a closed space. If you're driving for hours, people are going to drink, they're going to sleep. It's hard to wear a mask. So just containing it would be very, very difficult if you were able to determine that it was a true high-risk exposure. So that I think if one of the people really was brewing COVID, I think the odds of being in a car for a long trip, it'd be pretty likely that the entire family would have it by the end of the trip. So I think you need to know a lot of the details, but I think not knowing anything, I'd say I'm not sure I would do it, but it would depend on a lot of the details.
It's tough to say. Dr. Sinnott, one of the hot areas politically has been vaccines. when I saw a TV pundit was asked when he would have a vaccine, he said, right after Dr. Fauci. So could you give us an update on vaccines? And there's a lot of them going on, and is all of this hype and PR from the companies that make it, hoping to get investors in their company, or is there real promise in these vaccines?
I would say yes to both. Certainly venture capital would be interested in any vaccine that everyone in the world is going to need. I mean, what an attractive deal. I'll buy into that. Now, they're also using novel vaccines, RNA-based vaccines, etc. They're also using viral vectors. No one has used these vaccines. Actually, at USF, we'll be doing some studies, but right now we're using a viral vector, not for COVID, but for hemophilia. And when they tried that at Pennsylvania, one of the first recipients died. So the vaccine research area is a high-risk, problem-prone area. And many times problems with vaccine, the rotavirus vaccine, for instance, wasn't apparent until 3 years later. So these need exhaustive testing. We don't want to do more harm than good. I don't think this is something that should be rushed. I don't think I'd be the first to get a vaccine. I certainly wouldn't be the last. But we need to see, number one, how effective they are. And would you take an experimental vaccine if it were like the flu vaccine? It might be 25% effective. It might be 80%. But since it's untested, it might have some really serious side effects. So the vaccine story is one that will be played out like, I think, more like a novel than a short story.
Interesting. I know we all of us on here, I do remember the Guillain-Barré issues back in the, under Gerald Ford. That was sort of an interesting thing. I think there were about 500 cases, not that many. It is interesting that our country has been criticized for people refusing to have vaccines, as much as half the people in this country refuse to have vaccines. It is interesting to note that we've had over 300,000 people volunteer to be part of these vaccine trials. So there's a lot of good-hearted people as well. So Dr. Lockwood, I wanted to ask you a little bit about your medical students. There's a question that was sent in. First of all, congratulations on building a wonderful medical school. It's really the ascent of USF in the last few years has been remarkable. So my question is, what are y'all doing at the medical school? I know you postponed the spring break. Is there something, or do medical students get special care? Do they get more testing than average people because they might be exposed? Are you changing their clinical programs for them?
So our initial response, of course, back in March was to go online. And that persisted until July. In July, we brought back the third and fourth year students, and we were able to do that. We tested them all. We found that I think 3 of them were positive. They'd gotten community-acquired cases, so there was some delay, but the rest of them were negative. And then we were initially testing them every week, and then our rising second years started back, and then our new first years came in, and they all had been tested before they arrived. And so initially we were testing the students every week, and then we moved to every other week, and now we're testing a cohort every once a month. So they're every week we're pool testing the whole class. And pool testing is more efficient, and it allows us to, we haven't had any positives, so that's been good. But it's a much more efficient way of doing it. And those assays can be run in research labs, which is even super cheap and expensive. And it's part of a pool testing strategy that we're rolling out across the campus. We do about 300 people a week at random across the campus, and we do all of our athletes. For example, the football team, they're tested every other day. again with pool testing. So it's really been it's allowed us to have a order of magnitude more efficient and much cheaper approach to screening the population. So the students, our medical students, of course, are now on their regular schedule. Everything's back to normal. And they don't have the same schedule as the main university. So all the stuff you hear about spring break and they're going to go online, we don't do any of that. It's pretty much business as usual. There's fewer lectures, although we've gone back to some lectures, and a lot of lectures are online. Of course, we always have been doing that. We tape all of our lectures, and the students can access them whenever they want. Small group learning has returned and pretty much back to normal. The students were able to take their step 1 and step 2 exams because we became one of the national testing sites. 10 medical schools across the country were awarded kind of a limited franchise when the normal testing sites were all shut down. It was a huge backlog. So our students got first dibs. So they're all caught up with step 1 and step 2. By the way, their average step 1 scores for the group that just took it were 243, and their average step 2 scores were 250. So that's got, not only do we have the highest MCAT scores in the state, and
excellent.
Right, but we ain't screwing up once they're here. We're doing pretty good with their education. So they're doing great. They're very compliant with face masks and social distancing. They have a great attitude. Things going really well.
Well, that's a great thing. Dr. Holt, so Tampa made the national news recently for testing at Tampa International Airport. What is your take on that? Do you think that's a good idea?
Yeah, it's we are a pilot. We're actually learning, and I've been involved with the CDC and Baycare, the partners, in designing a program. I think it's well intended, but we're still working things out. The ideal, what it started off, was going to be pre-screening, particularly for those that were doing international or some other distances where they had time to do the PCR testing. But they also rolled out the antigen testing, not quite at the gate, but basically on premises at the airport. And that's a very different testing the situation. So we have actually already had a positive, and fortunately they agreed to get off, not to board the plane. But interestingly enough, we don't have a lot of enforcement powers, so we have to use our goodwill, if you will, to encourage them to do this. So with time, I think we'll have a better design. For those that are returning travelers, I think it's a great service because many times, when they arrive and if they have plans to meet with families or other things, they can get that test right there and carry on their way. Really no interruption. But with some of these testing, if you're gonna, if you're sitting at the lounge and decide to get a test before you get on board, you may not get on board. So
Okay.
that's part of the technology. We don't have the perfect test to screen asymptomatic people.
You're using a rapid test there?
They are, yeah. And it introduces the whole contact tracing. All it would take was somebody to get positive, get on board. 2 flights later, we've got several planes that we have to notify. And interesting enough, there is no enforcement to stop anyone unless you have already put them on the list. So it's a timing issue, literally getting everything done within that boarding time. So it's a lot of education. People need to be well informed about the value of the test, the purpose, and the consequences.
The CDC puts out a missive on air flight, and the implication being that it's pretty safe, that the way the HEP and the HVAC systems are done on airplanes, and there have been very, very few cases that have been linked to catching the virus on board an airplane. Would you agree that air flight in general is reasonably safe?
Yeah, I think once you get on board and it's getting there and getting, through the airport, through the gate, onto the plane. But once you're on board, that's a very safe environment. As long as everyone is compliant with their mask, and even those, if you happen to have someone on the plane, the circulation is really going to be focused more on your immediate proximity. So, but getting to and off to and from the plane, that's where the risks are. And anytime you're going to have people and crowds together.
And the destination. I flew a couple of weeks ago and there was nobody in the airport, so that was helpful. Dr. Kim, so flu season is coming upon us. The questions are, when should one get a flu shot? And then how, if a patient comes to you and they have symptoms, is there any way you would recommend to tell, do they have the flu? Do they have COVID? Would you test for both?
Well, I think everyone should get a flu shot. And I think it's going to be very difficult to tell whether they have COVID or flu. The syndromes overlap, fairly significantly. And I think if that's one of the things that we're struggling with, in all our clinical sites. When do you test? How do you test? And things like that. I think if rapid testing for both is available, either in a rapid test or something that's a molecular test that's reasonably good turnaround, I would try to test for both. But it's going to be a difficult problem because I don't actually think that you could reliably tell one versus the other. I think I would be very curious to see what my colleagues who've dealt with many of these other epidemics think about what we should do, because I think it's going to be very hard if we have a big concurrent outbreaks here in Tampa.
Very good. Dr. Sinnott, here's a question. There have been continued concerns regarding another spike in the fall. You are famous for predicting that we would spike here the first day or two of August. So what are your predictions for Florida going forward over the next few months? I think we're settling into about how many people are going to be safe and wearing masks and what kind of crowd control. And of course, Governor DeSantis has opened up the state across the board. What predictions would you have for going forward?
I think November has the potential to be a difficult month. I noticed a statistic done by one of the polling firms. It was just yesterday, and they found that 21% more of the population had changed their mind about masks because of the president's illness and would now begin wearing masks, which is actually very important information in stopping the spread of this, because they'll also stop the spread of influenza. So if people are really going to wear masks, we're going to have less flu and less COVID, which would be ideal. Clinically, you can't tell them apart. And as Kami said, you've got to test for both, because just having a negative flu doesn't mean they don't have COVID.
Very, very, very true. Let's see here. Okay. Okay. So Dr. Lockwood, when do you think we'll get back to normal in this country?
Well, I'm maybe more bullish about vaccines than some of my other colleagues, but I also have this hanking feeling that we have more T-cell immunity than we appreciate, as we talked about earlier. And if you put all that together, and we really can start rolling out the vaccine in January to March, then somewhere between April and July, I think the world might actually look familiar to us.
Yeah, interesting. Very good.
Could I make a comment to that? And I hate to argue with my boss, but I would compare this in a way to 9/11. And I'm not sure we'll ever get back to what normal is. There's going to be a pushback by the American public on vaccines. There's going to be holdups on production. There's going to be unexpected side effects. I think in next spring, we're going to have to just accept the fact that it's become endemic and proceed on that basis.
Yeah, I think, yeah, I don't disagree. I absolutely do think it will become endemic, just like all the other coronaviruses are endemic. It'll just enter the panoply of the 25% of colds we get that are due to coronavirus is just going to fit with the beta coronavirus family. So I think that's very true, but not to the extent, not the pathology that we saw, what we're seeing with this initial phase of it. Yeah, no, my assumption is based on two things. One, that people will act in a rational way that will preserve self-preservation, and that they'll want to get back out into the world, and therefore they'll be willing to have their immunity confirmed in some way. And the second is that we're not going to see a lot of side effects, particularly from the RNA-based viruses that don't seem to be generating much in the way of side effects. The adenovirus-based vaccines do seem to be showing more side effects. They're also more potent. They're also probably inducing higher antibody and T-cell immunity levels, but I don't think we probably need that level. I think we need enough to have your immune system have your yearly coronavirus cold, and that's fine. So yeah, we'll see. I mean, it'll be really interesting to see whether there's a rebound in Florida. If there's not, then we were the natural experiment, and it will tell us a lot about the biology of this virus. But yeah, all your points are very, very well taken, and you did predict August. So you know, who am I to get in the way of the great prophet?
Well, that's a good point. It's a, you know, like you said, after 9/11, everything changed and has always been different since that time. I would imagine it'll be the case with this. Dr. Holt, this is a little bit of a complicated question sent in by one of our colleagues. As parents, we are using the confirmed positive community rate provided by the Florida Department of Health and the Hillsborough County COVID dashboard to compare to the positivity rate at our children's school. If the rate at school becomes higher than the general community, then we know there is a problem. My questions are, what is the best way to determine a community positivity rate, as there is usually a discrepancy between the data Hillsborough County is using versus the Florida Department of Health? For instance, the Florida Department of Health had Hillsborough County at 4.81% versus 4.23% the week before. Hillsborough County COVID dashboard had Hillsborough County's 14-day rolling average at 5.55%. Why is there a difference in the number? What data is Hillsborough County using versus the Florida Department of Health? And finally, how do we compare our child's school to the community at large?
Yeah, it is complicated, but it's a great question because positivity has been emphasized a lot. It's become sort of part of the common vernacular. There are at least 4 different ways positivities are measured. And even on the Department of Health website, there are 2 separate ones. So if you look at a daily report that they have at each of the county, basically it just takes the total number of tests that were administered and any positives, if they're included, if they're duplicates, it's all about duplication. If it's a duplicate positive, they take it out of the numerator. And if it's a duplicate negative, they're left in. So those numbers are always probably lower than, because they're skewing it a little bit. The 7-day average is the one that is on the dashboard, and it's linked to the county. That is, you have taken out all of the people who have tested only once during that week. So if they tested multiple times, they're removed from both the numerator and the denominator. So it has a more valid prediction or credibility. And it's generally going to be a little higher than the daily ones that have been reported. There are other ways to calculate, Johns Hopkins and some others. You'll see some very wide variations. Probably the most important thing to notice for us is just trending and not focus on the exact number, because they will trend the same. As far as comparing your schools and your community, first off, your school's community is part of our community. There's really no difference. And all we're seeing in the schools are not transmission within the schools. It's transmission that is occurring in the community then brought into the schools. So, there is no real positivity rate for individual schools. We are reporting it. They are reporting cases. The kids that are getting infected to date all have common activities that are going on outside of the school. We're not seeing secondary transmission inside classrooms. The one thing I do watch and pay particular attention to in the schools are less the impact on the students, but the teachers. And if I start seeing the teachers increasing in the certain schools, then I do worry, because usually when you talk to them and you're contact tracing, they have a much more limited risk of exposure. Work exposure is one of their primary ones. So the risk of them acquiring it at school is probably comparable to their house, whereas with the students, it's all of their other extracurricular activities. So long story short, the positivity rate, watch the trends, don't worry about the exact numbers. And the schools right now, they're doing a good job with their preventions from transmissions, and I'm keeping an eye on the teachers.
What kind of a lag time would you expect after DeSantis lifting some of these sanctions before we start to see that trend changing, so that you might attribute it to those changes? Of course, we have tourists coming into Florida in the next few weeks or months as well, so we want to have our population increase.
Yeah, September was a big month for us. I mean, when you think about it, from the beginning of the opening of schools, we had, Labor Day, we had the executive order for the bars that were opening. So each of those, we're over 2 weeks, and generally you're going to be looking at about a 3-week period where the impact of some change would most likely begin to be manifest, at least in the early indicators, which are cases. And so far, what we've seen is pretty much we've plateaued. If you look at we've come down the Rocky Mountains, we went some rolling, and now we're up on a pretty high prairie, pretty elevated prairie. We're not where we need to be. It certainly is a lot better than where we were in mid-July, but when you look at our cases per day, 150 average, some multiple of that for actual cases, we certainly have plenty of kindling being burned right now.
I see. What would be a number that you would like to see? And other panelists, please kick in if you have something to add to this. What would be the number you would like to see that you'd feel comfortable with? 0, of course, but other than 0.
Yeah. Well, I mean, there has been the metric that people have talked about, which we'd like, which would suggest that the virus is suppressed, would be that we are seeing about 1 case per 100,000. For our community, that would be 15 cases a day.
So we've got 10 times that now.
Yeah, and in the early May, we were at 25 or 30 cases. So it wasn't that long ago. We had probably a 2 or 3% positivity rate in that early part of May. So we went up fast. We knew it was going to take longer to come down. We're sort of at a critical balance point, tipping point, if you will. I am optimistic, as Dr. Lockwood has talked about, that there is some degree of some partial immunities and some other things. But I also fear what Dr. Sinnott talks about, and I think the biggest thing is not immediate, will be Thanksgiving. I'm very concerned about that's when the families are most mobile. People are coming from all over. If you're going to see a combination of that, that's just ripe for all the
Okay.
I mean, if I could just add a couple of things. One is that when you track the age of cases in Hillsborough County, we started lower than the state, substantially lower than the state, which accounted for a very low case fatality rate. We crept up. We got to about 42 an average age, and now we're back down to about 34. So definitely the folks that are getting infected, that's a rolling average. So the predominant number of folks that are getting infected currently are younger people that are obviously at much lower risk. And, it's been interesting that when you track hospitalizations, we've been under 10, we've been under 5 per day now for the last couple of weeks. Deaths are still, they're the most lagging indicator, and they continue to actually in some days exceed the number of hospitalizations. Although today I noticed we were -4, so apparently we resurrected more people.
That's right. That's Easter, I think, is when you mentioned.
Right. Easter came early this year. So that's interesting. The other thing that I think I know that Dr. Holt looks at very carefully, and I do every day, is the occurrence of influenza-like illnesses and COVID-like illnesses to emergency rooms. And the COVID-like illness visits keep dropping across the state and in Hillsborough. Influenza is a little more parallel, and I think we're beginning to see real influenza starting to rear its ugly head in the state and in the county. But I completely agree with Doug's 1 per 100,000. If we get to that level, we're in great shape. The R value of the virus is like 0.1, and it's really petering out. We're at about roughly 10 times that, so about 10 per 100,000. That's much better than we were, 3 months ago. Way much better. So, although it has plateaued and it's a high mesa, as Doug would say, we're certainly in much better shape than we were, and the demographics of it have changed, and with that, a tremendous reduction in the number of hospitalizations. So that's all good news, I think.
Absolutely. Dr. Kim, this is a question for you. First, congratulations to USF and to Dr. Lockwood for receiving national attention on creating an electronic nose that can sniff out biochemicals created by COVID-19. A recent article reported on a prospective treatment developed by USF and Tampa General that is similar to remdesivir. Dr. Kim, you were quoted in the article about its effectiveness. Can you expand?
I think there was a little bit of miscommunication here. We're participating in a bunch of national clinical trials from various pharmaceutical companies. We early on did get remdesivir on compassionate use, and that obviously has what's called an EUA, so sort of partial tentative approval from the FDA. And then we're also participating in other experimental trials, including the Regeneron monoclonal antibody study, which is a cocktail of monoclonal antibodies to the spike protein of the coronavirus. And that antibody cocktail is what President Trump got last week when he was in the hospital. So that's truly experimental, but very promising. Eli Lilly has similar drugs that they also found very promising, and they've actually applied for an EUA. So we're participating in those trials of potential therapeutics, and we're also participating in several other trials that have had a little bit less publicity.
I see. Well, congratulations. I'm glad to see that you guys are in the forefront of that. That's good for our community, no doubt about it. Dr. Sinnott, there are predictions that the death toll in the U.S. will climb to 400,000 by the end of the year. I think we're at about 210, 220 somewhere now. Well, do you think that's a possibility, or do you have any sense on that?
I saw that number 400,000. And then we're dealing with a moving target. I think the comparison someone said is we're trying to fix the airplane while we're flying it. I don't think they'll go that high because I think the president's illness has sensitized a lot of people that say we're not believers or we're worried that it wasn't that contagious. But overnight, for 21% of the population to change their mind about masks is very important. If we get another 20%, it won't be 400,000.
So it's really based on behavior of the population in general,
Yeah.
what that number will be. Yeah.
You know, it's the only disease I know of that we can control by sitting home on the couch, eating Cheetos and watching TV. And no one's doing that.
Unfortunately, that will create some other diseases. I'm not sure we're recommending that. Yeah. Okay, let's see. Dr. Lockwood, COVID-19 case numbers are increasing, especially in some Western states. But how do these numbers compare with Florida and these and the curve of death rate? In other words, I guess they had mentioned the lagging indicators. You had mentioned lagging indicators before. So when you look at these COVID numbers, do you look at numbers of cases? Do you look at hospitalizations? Do you look at deaths? And how does Florida compare with the rest of the country in general?
Well, the virus is a forest fire, like out in California, and it's looking for dry tinder. And so the dry tinder right now is in Nebraska, North Dakota, South Dakota, and actually, interestingly enough, in Wisconsin. And so, that's where it's raging, just like it did in New York, just like it did here and across the Sun Belt in the summer and into California. So if you look at the end of the story, I think we definitely had a little bit higher per capita cases. We're not the highest. I think we're 15th per capita amongst the U.S. states so far. But we actually had a pretty low case fatality rate. And considering that we have the greatest percentage of folks over 75, over 85, over 65, we're not quite the oldest state of the union. Iowa is actually the oldest state of the union, interestingly enough, but we're real close. We should have had a very high case fatality rate. And New York City's overall case fatality rate is about 8.5%. And in Hillsborough County, it's about 1.5%. So something's different. And I leave it to Cammie to tell us whether it was because we began to be exposed to a different genotype of the virus, or whether or not it was because we were better prepared. Our doctors are better. We were certainly ready for it compared to New York. We had ventilators and ICUs and just
one word, steroids.
Well, yeah, and so we implemented dexamethasone almost immediately. We implemented convalescent plasma therapy within a week of the lockdown at Tampa General. Cammie and her team were super aggressive about using remdesivir. So a lot of the key agents were in place just as it hit us. Mm-hmm. And so we never quite got overwhelmed. We got close. We never quite ran out of PPE. We got close. And I think that made a big difference. And we also learned from the New York experience about prone ventilation and all the other respiratory therapy techniques that helped us. So I think I wouldn't give us an A, but I think Florida deserves a good solid B-, whereas a lot of the country gets an F.
Dr. Holt, here's one from a practicing physician. As you know, we've had recent lifting of sanctions by DeSantis for restaurants, bars, that sort of thing. What recommendations do you have for private practice physicians continuing mask rules in their office once the county or city no longer has mask mandates. So would a doctor's office be a special or a different place?
Well, no matter what the mask order will go away. The recommendation to wear masks indoors will continue, and I will continue to endorse that. I will continue to use that. And so if I was running a practice, I think my patients would expect my physicians, their staff, and the other patients to all be wearing masks. And I would continue that indefinitely for right now.
Okay, very good. Okay, Dr. Kim, among which groups is the virus mostly spreading, and are we doing contact tracing in this area?
Well, the contact tracing, I think we should ask Dr. Holt about. And I think we have the same problem that a lot of places do, that I don't think it's quite as bad at USF and, University of Tampa as it is in some university towns and university campuses. But I think younger people still have a little bit of air of invincibility. So I think it is spreading in some of the younger age groups, and then they go and give it to other people that they interact with. So I think that's unfortunately still true, and people are still going to parties and bars and doing things that I would rather that they didn't do. As far as the contact tracing, I think I'm going to defer to Doug to answer that question.
Yeah, the age group, our 18 to 24s, are leading the surge, or leading the pack, if you will, as Dean Lockwood talked about. That's in our younger group. Some of the little later in the teenagers, if you look 15 to 17, they're a bit of an uptick, but not significantly. As far as our contact tracing, we're still running. The biggest challenge we have is cooperation. The test and turnaround time is improved significantly. We've implemented automatic texting to make first contact immediately, but it's more of a matter of getting the time to do the full interview with someone. And we're running it's typically about 45 to 50% of our cases that we're able, within a 48-hour period, of reaching them and getting them to actually give us useful information. And that's the essence of contact tracing, because if you're not able to know where they have been and who they've been around, all you're doing is just, putting a little number in your accounting. So we're getting better, but clearly we're not going to contact trace our way out of it right now.
I think it's probably overwhelmed your resources. I doubt you could have enough folks to do it. Dr. Kim, the CDC has issued a new warning about a deadly COVID complication long after beating the virus, called MIS-A, which is a multi-system inflammatory syndrome. Are you familiar with that?
Yes. It's mostly a pediatric syndrome. So I haven't actually seen it. I've seen plenty of COVID, but I actually haven't seen any MIS, just because it tends to hit a different demographic, older children. So, but yes, we've not had too much. I think we've only had a handful of cases that we've seen at Tampa General. And it does seem to be a sort of vasculitic, inflammatory syndrome. And I don't think that we really quite understand why that happens to children. It seems to be more common in areas where there's been a lot of COVID. But I think, that's an area of great interest. And obviously, if we understood it a little bit better, we'd know how to treat it. I think the hypothesis is that it's an inflammatory complication. So a reflection of your immune system gotten hyperactive and then causing an autoimmune type phenomenon. But I don't think actually anybody knows.
Okay. And the last question, I think we're coming to an end here. Dr. Sinnott, what is a super spreader, and why are some people super spreaders and some aren't?
Well, that's certainly $1 million question. Super spreaders are people that infect a disproportionate share of other people. If we consider that the average ill person infects roughly 2 other people, super spreaders can infect 9, 10, or even more. It's unclear whether they have a higher viral load. It's unclear if they project their voice differently, and the timber actually allows more aerosolization versus droplets to form. I tend to go with a higher viral burden, and people that are doing a lot of mingling with other people, because if you're not mingling, you're not spreading it. The identification of super spreaders is critical, because if you look at the White House right now, if they really wanted to, and I don't think they do, they would find a super spreader there.
Well, we won't go into that. I want to thank our panelists, but I'll tell you what a fascinating evening. The hour went by very quickly. Thank you all for your time. It's a lot of knowledge. And I think there was a lot of clarity, which I think is an underappreciated thing in life. But thank you all so very much. Everyone be careful and be safe. God bless.